Started, ma'am.
Yeah, thank you. Welcome to all. This is our third FOGSI ICOG Journal Club, and we are doing it with the prestigious All India Institute of Medical Sciences, New Delhi. It's my honor to welcome all of you to this program. Respected Lakshmi Shikande, Madam, the Chair of ICOG, Dr. Parag Biniwale, the Vice Chair of ICOG, the esteemed coordinator, Dr. Neerja Batla, the HOD of the Department of ONG, AIMS Delhi, I would like to welcome Dr. Harishikesh Pai, Dr. Madhuri Patel, Dr. Ashok Kumar, Dr. Swarna Kadilkar, Dr. Geeta Balsarkar to this program. And it's my honor to welcome the international expert, Dr. Partha Basu, as well as the faculty for today. The MOC today is Dr. Seema Singhal, and the presenters are Dr. Divya, Dr. Himakshi, and Dr. Aishu. And esteemed experts from the national level have joined. Dr. Bhagi Lakshmi Naik, Dr. Sarita Balarao, Dr. Sarita Shamsundar, Professor Garima Kachwa, Dr. Madhuri Patil, and Dr. Priya Bave, as well as to every delegate who has joined for this program and all the students who have joined. May I have the, I'll just share this slide. So I would like to now introduce Dr. Lakshmi Shikande, Madam, who doesn't need any introduction. She has done so much of academic activities in FOGSI as well as for ICOG. And she's a national corresponding editor of the Journal Jogi. Ma'am. Yeah, she's received several awards, and I would like to welcome ma'am to give her overview of the program before we start. Thank you so much.
Very good evening to one and all. Since Charmila has taken everyone's name, I won't repeat. I welcome all the speakers, presenters, the chairpersons, experts, and special warm welcome to our international expert, Dr. Partha Basu, who will log in shortly. And I convey my thanks to Dr. Neerja for taking this initiative. Today's third journal club is from her institute, that is AIMS Delhi. Now I can see Dr. Partha, he has logged in. Dr. Partha, very warm welcome to India, though it is virtual on this FOGSI ICOG platform. And I can see my governing council members, Dr. Madhuri is here, Bhagya is here, Dr. Parag, our vice chair, is here. So without wasting much time, I hand over back to Dr. Charmila to start the proceedings for our third journal club. Charmila?
Yeah, thank you so much, ma'am. I would like to introduce Dr. Neerja Batla, the professor and head Department of Obstetrics and Gynecology, AIMS Delhi. And she's a Shobha S. Vengat distinguished professor of gynec oncology. Is a council member of the Asian Society of Gynec Oncology, member of several bodies, technical bodies and academic bodies throughout the world. He's edited several articles, is the editor of several books and articles, has authored several articles and is presented almost 700 lectures and national and international conferences. He's involved in numerous research projects and clinical trials. My request Dr. Neerja to give an introduction to the program because she has done so much for us. I've actually like every day I've irritated her so much, and I hope I've not troubled you lots, but because we needed the academic input from such a great institution for the journal club. Thank you so much for all the help you've done, Dr. Neerja.
Thank you very much, Dr. Charmila. Thank you, Dr. Lakshmi, Dr. Parag, for inviting us. In fact, not at all you have troubled us. We are very much obliged that you have selected us as one of the host institutions for your journal club series, which I think is a very good development that is continuing in ICOG, because this is important for people to know that what is the latest research coming out. And we hope that today we have been able to curate some articles which have a bearing on our management and our clinical approach and our preventive strategies, which are important for our country. So that is how we selected these articles, which the first one, we are part of that multi-center trial, which was initiated by Dr. Shankar Narayan and now carried on very ably and with new dimensions by Dr. Partha Basu. And we are very much obliged that he is here himself to give his comments on it. A very serendipitous type of situation which evolved out of a trial which was planned in one way, went in another, and gave us a great direction and has led to an enormous impact, not here just, but also internationally. So, you will hear comments from Dr. Partha, which will be very illuminating and very insightful and very exciting new vistas of research that are appearing. And we also have with us, and then the other second article, which was about portable colposcopes, because, one is aspect of vaccination, one aspect of screening, and how to take the screening to the masses. But forget the masses. When we see our gynecologists in their clinics, I'm really happy to learn that there are many gynecologists now, even in last AICOG, who are taking the message of portable colposcopes, thermal ablation, right in their own clinics, because who wants to keep that huge equipment when you can keep a small battery powered equipment and do the job so well. So I think that is also a very interesting paper. And the third one, which Dr. Garima has been the lead author on. So I think it's going to be a treat, and I'm not going to say any more to stand in the way of this.
Thank you. Thank you so much, Dr. Nija. Parag, want to say something before we start the academic session?
No, thank you, Sharmila. Good evening, all. Welcome to the ICOG Journal Club. We are looking forward to an exciting session today, and with Nirja as the lead, I'm sure it is going to be a great learning experience. Of course, thank you, Dr. Partha Basu, for joining. Thank you.
Thank you, Parag. Thank you so much. Now we go on to the program, and it's my honor to introduce all the experts for today. Dr. Partha Basu is the head Cancer Early Detection and Prevention branch. He's the international expert today. He's affiliated to the International Agency for Research on Cancer, WHO, Lyon, France. His areas of interest are in cancer prevention and early detection, the quality in cancer screening, and planning and implementing cancer control programs. He has published in almost 234 journals, which includes Nature, Lancet Oncology, and others. He's got more than 6,000 citations. He's got research funding from NIH, NCI USA, the Bill and Melinda Gates Foundation, the European Commission, the Medical Research Council UK, the Norwegian Research Council, the Global Alliance for Chronic Diseases, and the American Cancer Society. We'd like to welcome Dr. Partha Basu to the program. The first national expert is Dr. Sarita Bellarao. She is a obstetrician gynecologist from Mumbai. She's an immediate past president of the Mumbai Society. She's a governing council member of ICOG, the joint secretary of FOGSI in 2017. She's in the past president of the AMWI Mumbai branch, and she's been the quiz committee chairperson of FOGSI and past chapter secretary of IMS Mumbai. The next expert is Professor Magilakshmi Naik. She's a HOD Department of Gynec-Oncology from Cuttack. She's been the chairperson of the Oncology Committee of FOGSI. Is the governing council member of ICOG. Has been the vice president of AOG in India, and she's also published several articles, and she's been the assistant editor of the Indian Journal of Gynec-Oncology and the peer reviewer of the Indian Journal of Surgical Oncology. Welcome, Professor Bhagia, for the program. And the third national expert, we are extremely honored to welcome Dr. Sarita Shamsundar. She's a consultant and professor from Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, India. And she's the accredited colposcopist of the British Colposcopy Society, the immediate past president of the Indian Society of Colposcopy and Cervical Pathology. And she's been the board member of the International Federation of Colposcopy and Cervical Pathology. She's a master trainer for the MP State Government Screening Program. And she's the academic coordinator of the Dr. N.V. Gain Oncology Program at Safdarjung Hospital. Welcome to Dr. Sarita Shamsundar to the program. And for the third article, you've got a great expert on PCOS, Dr. Madhuri Patil, who is the governing council member of ICOG. She's a clinical director of Dr. Patil's Fertility and Endoscopic Clinic, Bangalore, editor-in-chief of the Journal of Human Reproductive Sciences, 2013 to 20, which is the official publication of ISAR. She's the associate editor of the Oncofertility Journal and the editorial board member of the Endocrine Society Journal of 2020 and 2021. Has been the leader in many organizations, and she's a member of the International Reproductive Medicine Research Network, has written several chapters and edited several books, and she's a vice president and founder member of the PCOS Society of India. And we're extremely happy to have you in the program, Dr. Madhuri ma'am. And the youngest, but one of the best people in research in India, Dr. Priya Bhavich Tower. She's a consultant and head department of reproductive medicine from Bansal Hospital, Bhopal. She's a FNB reproductive medicine teacher and is an ex-faculty of the DM reproductive medicine course. She's a FOGSI recognized trainer in basic and advanced infertility management course and is also a Cochrane reviewer and author. I'd like to welcome all the special experts to this program. And we always, it was always a pleasure to introduce Dr. Garima Kachwa, who's a professor in the Department of Obstetrics and Gynecology, AIIMS, Delhi. She's interested in high-risk pregnancy, gynec endoscopy, and reproductive endocrinology. The MOC for today is Dr. Seema Singhal, who has done such great work for this program, and she has coordinated all the activities of this program today. She's an additional professor at Department of Obstetrics and Gynecology at AIIMS, Delhi, and she's been awarded the UICC Fellowship in 2019 from New York, and she's also won the Dr. S. Radhakrishnan National Teachers Award, the OncoCare Legend Award, and the Best Paper Award of AOGN in 2022, and she's the treasurer of AOGN India. She's the organizing secretary of the Cadaver Dissection Workshop and CME in Gynae Oncology, and she has got several publications to her credit. May I now request Dr. Seema to take over the academic session, please.
Thank you, ma'am. And before we start, we would be very thankful to ICOG for giving us this wonderful opportunity to present the scientific sessions. The research that has been generated from AIIMS, or AIIMS has been a part of these research. And I would, without any delay, I would like to start the session, and I would introduce the first speaker for the day, who is Dr. Divya Sehra. Dr. Divya Sehra is our MCH Gynae Oncology resident and who's already finished her MRCOG. She's an ex-fellow Gynae Oncology, Rajiv Gandhi Cancer Institute, Delhi. And Dr. Divya will be presenting our first paper, and I hand over the mic to Dr. Divya.
You have to make it into a slideshow, Divya.
Yes, ma'am.
Perfect. Yeah.
Are my slides visible?
Visible, yeah.
Thank you, organizers, for this wonderful opportunity, and thank you, Nija Bhatla ma'am and Seema Singhal ma'am for guiding us throughout. So the journal to be discussed today, the first one is the evaluation of immune response to single dose of quadrivalent HPV vaccine at 10 years post-vaccination. It is a recently published article in the reputed journal Vaccine. The Vaccine journal is open access, the peer-reviewed journal. Publisher is Elsevier, and it is the official journal of the Japanese Society of Vaccinology. Editor-in-chief being Gregory A. Poland, with a high impact factor of 4.169. So a quick brush up. Low and middle income countries bear 85% of the global burden of cancer, but only a mere 41% have introduced HPV vaccine in their national immunization program. Only 15% of the girls globally received the complete doses of the vaccine till 2019. Even at the Gavi prices, the 2 doses of vaccine are unaffordable to many LMICs. Moreover, with the COVID pandemic, there is a disruption even in the high-income countries. So WHO has recently recommended single dose or 2-dose schedule based on the available evidence, and GCVI UK has also recommended switching to single dose regimen in the national immune programs. Durability of protection is important from the programmatic perspective. Costa Rica vaccine trial has demonstrated that the antibody response observed after 1 or 3 doses of bivalent vaccine remains stable throughout 11 years. Still, the long-term immunogenicity data is not available for the quadrivalent vaccine yet. Hence, coming to our study in question. So the primary objectives of this study were to determine whether the recipients of a single dose of quadrivalent HPV vaccine had sustained immune response against targeted HPV types at 10 years post-vaccination, and to assess whether the response was superior to the natural antibody titers observed in unvaccinated women. The secondary objective was to estimate the immune response against the vaccine-targeted HPV types at 10 years post-vaccination in the recipients of 3 doses and 2 doses of the quadrivalent vaccine. So before we come to the discussion of the journal, 2 very basic important facts about the HPV vaccine. One, that it is the vaccines are antigens that are compact into virus-like particles, the VLPs, which are highly ordered and closely the packed 3D structures, and that is why they are able to stimulate long-lived plasma cells and produce type-specific antibodies over many years. And this antibody, the vaccine is non-oncogenic, non-infective, but a potent immunogen. Also, the inferior level of antibodies seen after single dose vaccination are not compromising its effectiveness because of the unique natural history of HPV carcinogenesis. Because as the virus enters the mucosal surfaces, it tends to stay there at a longer time for several hours, and it binds to the cell surface receptors. The opsonization of the antigen-antibody complex takes place, and hence the inferior levels of antibodies are also protective. So, as described by Neerja ma'am, the initial study was initiated in September 2019 by the International Agency for Research on Cancer, also popularly known as the Indian IARC trial. It was to be held in 9 centers in rural area, and it was a cluster randomized controlled trial. And the aim was to compare the effectiveness of the 2 doses and 3 doses of quadrivalent HPV vaccine. But due to unexpected HPV vaccine suspension by the government of India on 8th April 2010, participants had received vaccines according to different vaccine schedules. This was an uncanny situation, and there were different ways how we could elaborate on this robust data. So, as of 8th April 2010, 17,729 subjects were recruited, as opposed to 20,000 girls between 10 to 18 years, which was planned earlier. Hence, we were left with 4 cohorts, majorly who had received 3 doses per protocol, 2 doses per protocol, that is 0 and 180 months, and 2 doses by default at 0 and 60 months, and 1 dose by default. So the different cohorts had different numbers. 4,348 being in the third 3 doses, 2 doses per protocol having 4,980 patients, and 1 dose by default recipients having were 4,949. We are not going to talk about 2 doses by default recipients, as that was the intention. So, because of this unexpected suspension, the randomized controlled trial was converted to a longitudinal prospective cohort study, and the participants were followed up yearly. The cervical specimens were collected after 18 months of marriage or 6 months after first childbirth, and after they achieved 25 years of age and got married, they were screened for cervical cancer. As for a post-hoc analysis, unvaccinated married women, about 1,484 women were matched by age and place of residence to the 18 to 21-year-old married participants during 2013 to 2015. So now coming to the current study in question. So using these cohorts, the participants of this trial, randomly selection of the different cohorts was undertaken. Blood samples were collected for immunogenicity analysis between February 2020 and July 2020. Of the single dose vaccine cohort, 340 recipients were randomly selected. Out of the 2 or 3 dose cohorts, 200 participants each were, so that means 200 for 2 doses, 200 for 3 doses were randomly selected. And amongst the unvaccinated women, 352 samples were collected. So this is a tabular, the data show the same data being showed in a tabular form. We can see the unvaccinated and the vaccinated cohorts and being tested for 2 antibodies. So the blood sample was collected and EDTA treated. It was stored at Rajiv Gandhi Center for Biotechnology, Trivandrum, at deep freezing, and they were transported in plasma aliquots, and they were shipped on dry ice to the testing laboratories. So the data, the samples were analyzed for two antibodies, the multiplex VLP-based IgG ELISA and the pseudovirion-based neutralization assay. The former one was analyzed at CDC USA, and the second one at the German Cancer Research Lab. So for the analysis, type-specific mean antibodies were calculated. The antibody response levels for the single and two-dose groups were compared with those induced in the three-dose group. Also, the antibody titers from the vaccinated recipients was compared with the natural immunity from the vaccinated cohort, unvaccinated cohort. And for the comparison, log transformed mean titers were used, and the geometric mean titers, that is the GMT ratios, were achieved, so that the comparison becomes more robust and easier. Coming to the results, this is a busy slide, but it is important to understand how the immunogenicity kinetics works. For HPV 16, we see the graph. We see that there is an orange dotted line which represents the antibody levels for the natural immunity or the unvaccinated recipients. There is a blue curve showing the antibody kinetics from the single dose recipients, and a green curve showing the ones with 3-dose recipients. So now we see that the levels of antibodies rise eagerly, they decline, and then they tend to plateau between 12 to 18 months, and the antibody levels remain stable throughout the 10 years. So the single dose recipients at 12 months had comparable antibody levels even at 10 years, which is 9 and 9.9 international units. The percentage of single dose recipients with detectable antibodies was major, about 96%. The ratio of GMT titers with the unvaccinated cohort was 2.05, means twice as likely of vaccinated patients would be having a higher GMT. And the ratio of GMT with compared to the 2 or 3 dose groups at 10 years was 0.28. So we are seeing that the antibody levels are inferior as compared to single dose recipients. And the same antibody kinetics was seen in the other antibodies, M9 ELISA and also the neutralization assay. It is important to note that the same kinetics were followed by other HPV vaccine types, that is HPV 18, 6, and 11. So when we see the graph, I'm just shifting back. So the graph tends to be similar for 16, 18, 6, and 11. So the article showed that the total and neutralizing antibody titers against the vaccine targeted HPV types plateau and remain constant till 10 years, as I said. A high proportion of the recipients of the single dose vaccine are able to have detectable antibodies even at 10 years. The antibodies are several fold higher in the vaccinated as compared to the unvaccinated girls, and it correlates well with data demonstrating vaccine efficacy at 10 years. Coming to, so there are, sorry, just give me 1 second, please. 1 second. I would just like to stop this screen share and go to another presentation because there's some slides missing. Just give me 1 moment, please. Are my slides visible? Are my slides visible?
Yes, visible. Yeah.
Okay. Sorry for the delay. So from the same trial, as I said, there have been previous publications because this is a landmark trial. And in Lancet Oncology 2016, the results of the immunogenicity data have been published. And it has shown that there are there is the immune response in the 2 group was non-inferior to the 3-dose group, and also there were detectable concentrations of neutralizing antibodies for all the types, but at much lower concentration for 2-dose or 1-dose recipients. Another publication by Dr. Basu sir and Dr. Basu in 2021 showed the adjusted vaccine efficacy against the different HPV types, and it is seen that the adjusted vaccine efficacy is comparable in the single-dose group as compared to the 2-dose and the 3-dose cohort group, and it is very high at about 95.4. Now, what does the international study say? Coming to the right side of the picture, we see we know that the Costa Rica HPV vaccine trial, the CVT trial, was initiated in 2004, and it showed that there are 10 times the level of antibody was induced after a single dose. But this trial has used bivalent vaccine. And the other study is from India, the IAC trial, and then the 2 randomized controlled trial data, one from Kenya and the other from Tanzania, has imparted considerably to the evidence of single dose vaccination. Coming to the CVT trial, this is an updated analysis published in 2020. The antibody titers did not qualitatively decline between the year 4 to 11 years, and also that the cervical HPV infections tended to be similar in all the 3 groups at 9 and 11 years. Kenshi was the randomized controlled trial, and it enrolled, and it was a multicentric trial at 3 centers in Kenya, and the enrollment was young women aged 15 to 20 years. They were randomized to receive either immediate nonavalent vaccine and delayed meningococcal vaccine, or immediate bivalent vaccine and delayed meningococcal vaccine, and the immediate meningococcal vaccine and delayed HPV, which served as the control arm. So when we see the efficacy, the modified intention to treat analysis shows that that the vaccine efficacy was similar in the nonavalent and the 2-dose groups for HPV 16 also, and HPV other types as well. This is a recent publication from Thailand, which is an observational community effectiveness study of single dose or 2-dose of the bivalent vaccine administered in a voluntary school-based program to grade 8 female students less than 15 years of age, and the reduction in the HPV vaccine type prevalence will be assessed in each province 2 and 4 years after vaccination by comparing HPV prevalence in the urine samples. So the study is likely to get completed in 2023. So with the available evidence, the WHO has suggested that the single dose has comparable efficacy and duration of protection as a 2-dose schedule, and may offer program advantage, be more efficient and affordable, and contribute to the improved coverage. Hence, the guidance was recently published, which says 1 or 2 dose. From the 2-dose schedule, it was switched over to 1 dose for girls 9 to 14 years, and also for 15 to 20 years of age. But a 2-dose schedule is recommended for girls older than 21 years. The strengths of the study are that it is the first study to compare immune responses between the single-dose recipients and naturally infected women for the quadrivalent vaccine. It used 2 independent technologies to assess antibody response performed at 2 different laboratories, and the analysts were blinded to the status of vaccination. Hence, still there are few limitations, like the control arm of the unvaccinated women was added post hoc. We do not know about the true seropositivity threshold of the antibodies till date. There might be a boosting effect from the natural infection on single-dose vaccine recipients, but we can't quantify that. And we do not know what will happen to those who had non-detectable antibody titers at 10 years. Perhaps a herd immunity will take care of these. And what is the implication of this study from the programmatic aspect? But we do know that single dose vaccine has immunogenicity. Now we are giving data for the long term durability of the antibody response after single dose. So single dose vaccination is likely to improve affordability and supply. It might lead to a significant reduction in the programmatic cost. It may also allow the multi-age cohort vaccination to take place, which was suspended. And also, even girls with only vaccination with 90% coverage can prevent 4.8 million deaths by 2070 in the LMICs. Thank you.
Divya, you can stop sharing.
Yes.
Thank you so much. That was well done, excellently done. May I now request first Professor Neerja to give her inputs before we ask opinion from the experts.
No, I think now we should ask Dr. Partha to give his opinion, as well as the other experts whom we have here. Dr. Bhagya Lakshmi is there, who has a lot of experience. Dr. Sarita Shamsundar is there, a lot of experience in preventive trials. We'd love to hear from them all.
Professor Partha, sir, your opinions on
that. Thank you, Neerja. Divya, it was an excellent presentation. Congratulations for that. Yes, this is a classic example of how Indian research has created a major global impact in terms of reducing the number of doses of the vaccine required for protection against, cervical cancer and other HPV-induced cancers. I mean, if you, as Divya presented, that till now, only 15% of the girls worldwide, they have been vaccinated against HPV. And there are three reasons for that. First and foremost reason is that this vaccine is no doubt very expensive. If you think of, the lowest price that has been achieved for any program, that has been through Gavi. And the Gavi price is $4.5 each dose. So the total, to procure 2 doses, the countries, they have to pay $9 per girl to be protected. Now, if you consider India, all the vaccines that we provide through our universal immunization program to protect against 10 different infections, the total cost of all those vaccines is $13. And here we are talking about one single vaccine that will cost $9 to procure. So the cost is a major factor. Then second thing is the crisis of supply. There is a major crisis in global supply of HPV vaccine. So many of the countries, they are not being able to introduce it. Third problem, and which is a major problem again, especially for the LMICs, is that the first dose coverage in the LMICs is actually higher as compared to high income countries. But when it comes to tracking down the girls again to give them the second dose, there is a significant drop in the second dose coverage. So what will be the single solution to all these three problems? That is switching to a single dose. So a single dose, the price will come down both for procuring the vaccine as well as administration charge. The global crisis, supply crisis will be taken care of. And then, we don't have to think about the second dose of the vaccine. So that way, this is really going to make a major impact in terms of elimination of cervical cancer. And, it's just not, for LMICs. Now, very recently, even Australia, which was the first country to introduce HPV vaccine. And that time, if you remember, it was even recommended 3 doses for young girls. So Australia very recently has changed to a single dose based on the recent WHO recommendation. But then for all the rest of the other countries, they are just asking one question. Okay, fine, it is showing great protection, but then how long is the protection going to last? So that is what we call durability of response. So our study again shows that beyond 10 years, we still have a sustained high level of antibody titer, which is protective. And then there is no, dip in the curve. The line, if you just draw it, it remains as a straight line. And Divya has explained why this vaccine is so immunogenic. It is essentially because of the VLP and the structure of the VLP, which has multiple epitopes on one single VLP. So one single VLP is acting like multiple antigenic stimulants. So it induces quite a robust immune reaction. So that is why till now, we have no concern about durability of the protection beyond at least 10 years of vaccination. But then certainly we'll keep the cohort under follow-up, and thanks to Professor Neerja Vatla and all the excellent collaborators we have in India, the cohort is still being followed up, and we hope to generate data after 15 years or even beyond. So that way, the Indian study will really drive the global vaccination, HPV vaccination agenda. So I'll stop here and we'll be happy to take any questions.
So in that study, the single dose had a lesser antibody level compared to the 3 doses regime which was given. So will it translate to a lesser immunity for these girls when they become older? Because suppose if they can afford the vaccine, will a 3 dose will be better than a single dose if the affordability is not a factor?
That's a very, very good question, Dr. Shamila. Indeed, we do see that with single dose, the immune reaction is inferior. But then this, as again Divya showed, that for this vaccine to protect against HPV persistent infection, you need very small amount of dose, because this works as a neutralizing antibody. And it neutralizes the virus at the point of entry. And the point of entry, the virus stays for quite some time. It has to undergo some epitomal changes. Unlike respiratory virus, for the respiratory virus, within a few minutes, it gets into the cells. But this virus stays there for a few hours, undergoes epitomal changes, and then only can get inside the cell. So at that point of time, you need a very small amount of antibody to protect, to neutralize the virus. And that is again reflected in all the data that are coming from the studies. So for example, we have our study where we have looked at persistent infection, protection against persistent infection, almost zero persistent HPV 16 and 18 infection. Same you have seen in Kenshi study, saying again 97% effectiveness. And then data is also coming from real life programs, where Australia, Sweden, Denmark, obviously in a real program, some girls will receive 1 dose, some will receive 2 doses, some receive 3 doses. So when we look at the effectiveness of single dose in these programs, again, we see exactly the same kind of effectiveness. So at the present moment, what we understand is this vaccine does not require a huge amount of antibody. And then we need not really unnecessarily go around vaccinating girls or women or even boys with 3 doses when a single dose is good enough. So one practice change that we'll have to immediately do is stop giving 3 doses to any age woman. In India, of course, it's men's vaccination is not yet permitted. I mean, the Serum Institute vaccine will be available for vaccinating boys or men. But then 3 doses are definitely not required at any age. For 2 doses, as I said, we have shown that for 10 years post-vaccination, there is absolutely very robust protection. And that's why the WHO said one can go for a single dose or can go for 2 doses. Because if you are concerned, yes, because we go by science. We cannot give prediction that, yes, this will be, because we are seeing now high protection, it will remain so over time. So we have to see. So if somebody has concern and somebody, as you said, in a private market, where affordability is not a concern, one can go for 2 doses, but then the gap between 2 doses should be at least 6 months. Even better is to increase it to 12 months. That gives you better antibody response. And then again, as Divya mentioned, that okay, in a real programmatic situation, some girls will have reduction in antibody. Okay, fine. They may have less protection, but then vaccine always works in the community through herd protection. So if you have a high coverage of exceeding 70%, and then those few girls will have less antibody response will be protected because of herd immunity.
Thank you so much, sir. Bhagya, your opinion on?
Yeah, I think, sir, that was actually, this was an eye opener for the whole world. We had the Kenshi trial again and the Costa Rica trial, but then we may think that the government did a wrong thing, but then this was, I think, as Dr. Neerja would tell it, this was serendipity that we had 3 cohorts and almost of the equal strength in all of them. But the only query I have, that WHO still tells that it's 1 to 2 doses. So it may not be expert comment, but I'd like to have Dr. Partha's comment on this, because still it is 1 to 2 doses. So when we tell the patient that 1 dose is enough, but the SAGE guidelines still tells that 1 to 2 doses. So where do we stand?
Yeah, exactly. As I said, I mean, there are the main issue which people are still debating is, okay, fine, we have shown the vaccine has shown protection with single dose, but will that protection last over time? So that is why, from a programmatic point of view,
Yes.
where you have an ongoing program with 2 doses, right? And you change to a single dose. Now, after 5 years or 10 years, you say, oh no, we have to change back to 2 doses. It becomes quite a bit of challenge for them. So, so WHO recommendation says that countries can go ahead with vaccination either with 1 dose or with 2 doses of the vaccine. So for LMICs, where what is the standard of care currently is no vaccination. So instead of no vaccination, going for single dose vaccine and achieving a high coverage, making sure there is a herd immunity will definitely have a huge impact in terms of even if the vaccine, say, for example, shows some reduction in effectiveness over time. We don't know. But then that we have shown by through modeling that even it comes down to from 95% to 80%. Even then, going for a single dose will be much more cost effective for countries like India and others rather than going for 2 doses of the vaccine. So one side is the programmatic perspective where we should go for a single dose. And the other is the individual private practice like situation where there is, as Dr. Sharmila said, affordability is not really a concern. Okay, you can go for 2 doses. And then what we are suggesting is to keep that gap 1 year or even beyond. In Mexico, what they did was they increased the gap to 3 years because they want to wait. And then by 3 years, we'll get more data and then giving us more information on the single dose protection. So then you can tell that, okay, come and get the second dose of vaccine if the single dose is shown to be having lower efficacy over time. So that's also in a private market, that's also a good approach.
Yes, then we all have to agree that a single dose will really pull us nearer to our goals of 90% girls being vaccinated by 2030. So I think that has to be taken up as a challenge because in LMICs, as sir has told that we have no vaccination. So at least 1 dose will really take us nearer to our goal. But then Sarvavac, I think there's no option of 1 dose as of now, the indigenous vaccine. So that has to be 2 doses until we have some studies to back it. Am I right?
Myself and Dr. Nija, we are in a meeting today, and then it seems that some of the states in India, they are going to introduce Sarvavac off level. It's called because they don't have data for single dose, but then it's essentially, the concept of, biological equivalence. So it's a biosimilar. The current Sarvavac is nothing but biosimilar to the Gardasil, which we tested, evaluated. So some states are going to go for a single dose of Sarvavac as an off-label use. That can do. The government has full right to do that.
Yes.
Professor Sarita. Thank you, Batu. Professor Sarita, your opinion.
Yes, thank you so much, Dr. Charmila, for this invitation, and I congratulate the entire team on this trial. But despite the government stopping the trial, they continued with assessing the data and following up all these women and getting the antibody levels and all that. And so we have excellent data even at the end of 10 years. So I really congratulate the team. What my question is, now, do we have any data on the number of, apart from the antibody levels, on the HPV infections and the numbers of CINs in the single dose and the 2 dose, 3 dose, and the unvaccinated? Do we have any data on that?
Yes, Dr. Saita. We have looked at efficacy against persistent HPV 16 and 18. As you know, that is the most important endpoint in terms of cervical carcinogenesis. And as compared to the unvaccinated women, the frequency of persistent HPV 16 and 18 was 24 times less. Okay. So it is zero, almost zero. We have in our but till now, we have evaluated at least, say, for example, 7,000 of the vaccinated participants for persistent infection and not only maybe 0.1% of them, they have HPV 16 and 18 infection. Whereas in the unvaccinated, we get it to 2.74% or 2.7% of them. So it's a significant reduction. Now, these women are still young, but some of them, they have reached the age of 25 years. And we have started, screening them using hybrid capture 2 test. And as those who are positive on hybrid capture 2 test, we are, going for colposcopy and biopsy. Till now, not a single case of HPV 16, 18 related CIN2, CIN3 has been detected. Whereas in the unvaccinated women, we have already detected 5 cases of CIN2, CIN3 associated with 16 and 18. So there also, you can see the early trend showing the protection against CIN2, CIN3. But then the best evidence for protection against CIN2, CIN3 has come from real programmatic data from Australia. Thousands of women who received single dose as a girl, below 15 years of age. Now, when they go for screening, the incidence of CIN2, CIN3 is almost 0 related to HPV 16 and 18.
Yes, that's excellent news. That's excellent.
Thank you so much, sir. Such clinical information, which is very useful to the practitioner, because most of us have not accepted, even in the private sector, when affordability is not a factor, that girls need to be vaccinated. So I think this will drive a very strong message to the clinicians who are attending also. I think Professor Neerja needs to give us more lessons and classes throughout the entire sector, because this needs to be understood. At least one vaccine, one dose of the vaccine at the young age is going to help them throughout their adulthood also. Thank you so much.
Absolutely, Charmila, I'm saying it, consider it like an insurance policy. Let's so many insurances we put in where we don't ever avail the benefits, so we don't mind it. Similarly, we should not assume that cancer has to happen. We should take it as an insurance.
Yes, thank you so much. Now we can go on to the next article, Seema.
Yeah, sure, ma'am. It was excellent. And now we'll start with the second presentation. And for starting the second presentation, I'll invite our dynamic junior resident, Dr. Himakshi Gar, who's a third-year MD resident, pursuing her MD Obstetrics and Gynecology. And she'll be presenting our second article, which is about the portable colposcopes. So without any further delay, I'll hand over this to Dr. Himakshi. Yeah, just a second. Are the slides visible?
Yeah, but you have to make, yeah, perfect. Too simple.
Very good afternoon to everyone. I'll be presenting an article from the journal, Asia Pacific Journal of Cancer Prevention. It's an open access journal, which is a monthly electronic journal, and it was launched in the year 2000. Since then, it has 8,000 articles under its name. The editor-in-chief is Alireza Mozavi Jarahi, and the impact factor is 2.5. The article which we'll be discussing is, can portable colposcope replace standard of care colposcope, a crossover trial of 2 portable colposcope with a standard of care video colposcope by Dr. Jayashree Natarajan et al. As we all know, two out of 3 women in the age group of 30 to 49 years have never been screened for cervical cancer. So there is an unmet need to screen a large population of women, especially in low and middle income countries. One of the most important goals of cervical cancer screening is to distinguish between the low grade and the high grade lesions. 2 approaches which has been proposed by WHO for screening and treatment are screen and treat approach, in which the decision to treat is based on a positive primary screening test only, whereas in screen, triage and treat approach, the decision to treat is based on a positive primary screening test followed by a positive second test known as a triage test, with or without histologically confirmed diagnosis. So a single visit approach can be a preferred modality, especially when the patient is likely to lose to follow-up, which is a common scenario experienced by doctors in Indian settings. So why do we need a colposcope in cervical precancer management? A colposcope provides a magnified view of the transformation zone. It can helps in taking biopsy from the worst affected area, and we can also give colposcopic guided treatment, and documentation of the cervical images can also be done. Above this, why a portable colposcope is upcoming these days? Because it has a potential to reach the last mile facilities where women are largely unscreened. And since it is a battery operated device, it reduces the dependence on a continuous supply of electricity. Telementoring and teleconsultation can also be done through the portable colposcopes. So this is a analogy to describe the following study, in which amongst these two, one would prefer going for a slim mobile, which is easier to carry and use. Similarly, in these, the portable colposcope, which is the pocket colposcope, and a gynocular stand over the standard colposcope in ease to use and easy to handle. The objective of the study was to conduct a side-by-side comparison of two portable colposcope with standard video colposcope and evaluating its potential to enable a single visit for screening and treatment of cervical precancers. It was a crossover randomized trial, which was conducted from September 2017 to June 2019. 250 women were recruited. This was based on a 3x3 comparison table with kappa statistics to detect significant difference with 80% power and making an allowance for up to 10% loss to follow up. It was conducted in colposcopic clinic of AIIMS, New Delhi. Few characteristics of pocket and gynocular. Pocket colposcope, as we all know, is a transvaginal device. On the contrary, gynocular is to be used outside the vagina, around 30 to 45 centimeters from the vaginal end. And since the pocket colposcope is kept inside the vagina, it autofocuses the cervix, and hence it can be used in the community settings. Whereas for gynocular, increased time is needed to stabilize the viewing system and focus the cervix. LED and cameras are fit at the tip of the colposcope, whereas for gynocular, high resolution cameras and light source are needed. The inclusion criteria of the study was age between 25 to 65 years. Any abnormal cervical screen result patients were recruited. Vaginal discharge for more than 6 months and any unhealthy cervix on examination were included in the study. The patients who were pregnant or had obvious cervical malignancy or had any previous treated or diagnosed CIN, previous hysterectomy, or any procedure performed on the cervix were not included in the study. A consort diagram to have a better understanding how the study proceeded. 250 participants were recruited. After automatic randomization, one set of participants underwent colposcopy with gynocular followed by pocket colposcope. On the other hand, one set went through first pocket colposcope followed by gynocular. Both of these set of population underwent colposcopy with standard colposcope, and a biopsy from a suspicious lesion was taken. In case there was no suspicious lesion based on the SWEET score more than or equal to 5, a 4-quadrant biopsy was taken. The biopsy was taken as a gold standard and it was used for interpreting the result. Stata 15.1 was used for statistical analysis. After the colposcopy was done, the colposcopists were given a questionnaire in which leading questions were asked regarding the ease of use and the image quality, and the scores were calculated. Coming on to the results, the mean age of the study population was 41 years. 1/3 of the study population belonged to low and middle socioeconomic status. Mean age of the marriage was 17 years and mean age of first pregnancy was 20 years. Majority of the population has coitus between 16 to 20 years. Majority had more than or equal to 2 children, and major population group were belonging to premenopausal group. The SWEET score of 3 colposcopes were calculated, and it was found that between pocket colposcope and video colposcope, 248 out of 250 women had identical sweet scores showing a high agreement, whereas in gynocular and video colposcope, 247 out of 250 women had identical scores, indicating an almost perfect agreement with a K-value of 0.995. The ROC curves showed that it was similar for gynocular, pocket colposcope, and standard colposcope, with high agreement in the outcome measures, having a area under the curve value of 0.96 for gynocular and pocket colposcope, whereas 0.91 for standard colposcope. A comparison with the gold standard, in cases with CIN more than or equal to 2, both portable colposcope had agreement score of 85.56, showing a moderate agreement, which was similar to video colposcope, having a similar agreement score of 85.5. As you all can see, in sweet score 0 to 4, majority were picked up as normal or CIN1 by histopathology report, and with a higher sweet score of 7 to 10, histopathology reports were reported as CIN2, CIN3 or higher. At sweet score more than or equal to 5, highest sensitivity was seen, whereas for sweet score more than or equal to 8, highest specificity and positive predictive value were obtained, indicating that any patient reporting with higher sweet score value more than or equal to 8 are can be undertaken for screen and treat, like treating in the same setting, whereas sweet score more than or equal to 5 can be used for follow-up. Optical characteristics comparison of the colposcope. Pocket colposcope scored better with the field of vision, ease of use, ease of taking biopsy, and subject compliance. This was calculated through the forms which were filled by the colposcopist at the end of the study. The image captured from gynocular and the pocket colposcope showed drastic changes, as in the pocket colposcope, it was a broader view of the image and a more clarity of the image was obtained. So pocket colposcope had a potential to be used in a screening facility to provide ablative treatment, as in settings where colposcopy as a triage test increases the optimal treatment rate from 52 to 92 and reduces the over rate from 46 to 4%. Whereas using HPV as the primary screening test followed by colposcope increases the optimal screening rate from 86 to 95% and reduce the over treatment rate from 13.6 to 0.8. Thereby, the pocket colposcope can be used in screen, triage, and treat approach to reduce the over treatment and under treatment rates. In May 2018, WHO called for elimination of cervical cancer, in which global strategy to eliminate the cancer was given by a 90-70-90 protocol, in which 90% of the girls should be fully vaccinated with HPV vaccine by the age of 15 years, 70% of the women should be screened with high performance tests such as HPV test by 35 and 45 years of age, and 90% of the women identified with cervical disease should receive treatment. Coming on to the demographic characteristics, as it was obtained in the study, it was seen in the literature, the mean age of the diagnosis of SIN2 and SIN3 and SIN and invasive cancers were 35, 41 and 51 years respectively. Age distribution of the study confirmed the validity of twice in a lifetime screening at 35 and 45 years as being recommended by WHO, which would pick up majority of the cases of more than or equal to SIN2 lesions. Comparison of the diagnostic accuracy of the standard colposcope, as obtained in a study, it was comparable sensitivity and almost comparable positive predictive value. In a study by Gonzi et al., an agreement of colposcope with and gynocular in assessment of cervical lesion by sweet score were calculated. It was a randomized controlled trial. In this, it was also found that comparable colposcopy results were obtained with gynocular and standard colposcope, and level of agreement in assessing cervical lesion was 70%, having a significance of more than or equal to 95% with p-value less than 0.001. In another study where portable pocket colposcope was compared to standard of care colposcope using acetic acid and Lugol's iodine as contrast medium by Mueller et al. Pocket colposcope, it was concluded that pocket colposcope performance was similar to that of the standard of care colposcope when used to identify precancers and cancerous lesion. The average sensitivity and specificity of the pocket colposcope was 71 and 57%, which was comparable to standard colposcope as 79 and 56%. Another study by Natarajan et al., in which feasibility and outcome of training field workers to use the transvaginal colposcope for point of care diagnosis and management of precancer cervical lesion. This was recently published in Indian Journal of Gynecological Oncology, in which the study was conducted in 2 phases. Women in the age group of 21 to 65 years were referred for colposcopy for an abnormal screening report, and they underwent via and followed by colposcopy, and comparing the performance of field workers in capturing the colposcopic image with transvaginal colposcope and the physician captured image using transvaginal colposcope and a video colposcope. In the phase 2, an experienced field worker and a new field worker captured image of cervix were assessed by the colposcopist. It was seen that out of total 125 subjects, 122 image captured by the field workers were adequate, and the sweet score calculated from the image captured by field worker and physician showed high level of agreement. Therefore, it was concluded that transvaginal colposcope can be used by field workers to capture cervical images, which can be reviewed by colposcopists to reduce the referral rate. The strength of the study was, it was a randomized trial. All the participants underwent screening and followed by biopsy, irrespective of the finding, thereby reducing the verification bias. The sample size were calculated as per statistics, whereas limitations were, it was an operator bias was present, and the results were extrapolated to a field setting, whereas the study was conducted in a colposcopic clinic. We can conclude from the study that pocket colposcope can reduce the overtreatment and the referral rate. Reducing the dropout rate ensures optimal treatment in the screening programs. With tele-mentoring in the pocket colposcope, less trained health professional can detect and take biopsy from the lesions. Portable colposcope has the potential to bridge gap in screening and triage, being more cost-effective, user-friendly, and easily accessible in low and middle-income countries. Thank you.
Thank you, Himakshi. Can you stop sharing?
Yes, ma'am.
Thank you so much. That was excellently done. Thank you so much for your care, because such clear slides, I think everybody could understand that. I saw Dr. Sarita asking a lot of questions in the chat box. I think you should be the first one to go, ma'am.
Can you?
Hi, Sarita.
Yes, yes.
For your question, whether colposcope is different for the portable and the video colposcope. So yes, they were different and they were blinded. Was
Okay.
the periwinkle handheld? No, this was not periwinkle. This is a colposcope which has been devised by Nimi Ramanujam and her team at Duke University in North Carolina. And they have recently started the commercialization, and what they have done is something very good. They have not handed it to any commercial company. They have gone through the Duke University platform. So I don't know if they've got a final price, but it's going to be a very, very low price that they are coming with, because they are not making it like a 10% markup type of thing over and above. Their cost is going to be very affordable. So the gynocular at that time, which we used was from Sweden, but unfortunately that company has now gone, it's closed down. But interestingly, that software was made in Hyderabad by an NRI, and they are now making what they are calling GynEye with the same software, and we are currently evaluating that. So yes, the video colposcopist was blinded to the results of the portable, and the pocket is compact, and but like I said, the cost is going to be good. The images were very clear and very comparable. Can you keep
the person doing using the portable colposcope, were they different? I mean, whether the set of the doctors using the portable, they were different.
That one did and went away, and the other one stepped in.
Okay. And so the experience was noted from the people using the portable colposcopes.
Yes.
Okay. Thank you.
And there's one question in the chat box. Can you do LEAP with the pocket colposcope?
So LEAP we have not tried, and it might be a bit of a challenge, but biopsy we could do very well. The endocervical speculum we could do very well. And LEAP, I'm not sure whether it will be feasible. I don't think so. I think it's very good for the field where you may want to do simple procedures.
And somebody's asking about artificial intelligence integration.
So this model was not, but the same team is carrying on. They're carrying on with a model which will allow even self-examination by the patient, the CALA device, and they are contributing to the NCI's public collection of images for artificial intelligence. So all these images have been fed into NCI's database already.
Bhakya?
So actually, this
Yes,
study has
and
been
we
very.
give report. We can give report because it's connected to the laptop.
Yes, but I don't have any personal, though we have seen the demonstration many times, but I have not used it personally. But I think we can really see the pictures, because from the video colposcopes which are available to us by boards and all those companies, I think the clarity of the images are much more with this pocket colposcope, and the ease of use I think is important. And then the backup of you can consult with someone else who is distantly placed is again another big advantage with this pocket colposcope. And they are, I'll assure you that they are more economical than the video colposcopes that are now available in the market.
You're using in your center, Bhakya?
No, this pocket colposcope, like we have, we are in the process of procuring it, but then we have not used it, but we have seen a lot of demonstration, and simplicity of use is also an important thing with the pocket colposcopes, because I think focusing and all those things with video colposcope, which is a real issue for beginners, is not going to be a problem with this pocket colposcope.
Yes, it's autofocus and it doesn't need any major. And it also, you don't need to adjust the distance also. Once you're there and you just.
And it just has to go into the vagina.
Yes. The other major advantage is, when you want to review the pictures, otherwise you have to go to the colposcope and take out the images. With this, if it's on cloud, you can, log in from anywhere and see the image and review. This is especially important when the patient comes with a biopsy report and you want to see, what is to be done for that particular lesion. So it's very helpful when, you're in the clinic and you can just review on the cloud online. You can just see the pictures. So that is really good.
Whenever it is available in the market, please tell us, Dr. Neerja. We'll put a word to everybody who wants to. It will be a cost-effective option and much better than the when you don't have greatly trained people. Probably this will be a better option for such centers, right?
Definitely, we will do that.
Any inputs from Dr. Partha Basu?
No, it was very interesting presentation, and the data really is very promising in terms of using this kind of compact models for field. And then especially, what was interesting was the data related to the reduction in overtreatment, because in screen and treat, certainly that is always a concern. But then when we see that, HPV positive women can be very easily triaged and then immediately they can be treated. I think that's a great application of this kind of devices.
Thank you so much, sir. Dr. Ashwini has joined. Ma'am, would you like to say something? Madam, you have to unmute yourself.
After the next presentation, I will give my comments.
Okay, ma'am. Thank you so much. Priya, would you? She's a reproductive medicine specialist, but any inputs from Priya from the research side? Any opinion from your side for both the papers?
I think the design of the study was really good, and I would want to congratulate the the people who conducted this research for a very wonderful study design, and that practically takes care of the two issues that we have, that is over treatment and inter-observer variability. So congratulations to the researchers.
Thank you so much, Priya. Seema, I think we can go on to the third paper now.
Sure, ma'am. We'll start with that. Thank you so much. And now we will start with our third article, which is a little different theme than the other previous two articles. So now we're starting with a very, very interesting topic, which is of interest to all. And it is about PCOS. And for presenting this article, I would like to invite our very intelligent and very sincere postgraduate student of third year MD resident from our department, Dr. Ayushi Negi. So who will be presenting this article under guidance of her guide, Dr. Garima Kachawa. So over to you, Ayushi.
Good evening, everyone. My article for today is from the International Journal of Gynecology and Obstetrics. It was founded in 1963, and it is a peer-reviewed medical journal. Editor is Richard Mervyn Coffey Ednew, and it is a monthly journal. Publisher is Ville, and an impact factor is of 4.447 that was given in 2021. My article for today is Efficacy of myo-inositol and D-chiro-inositol combination on menstrual cycle regulation and improving insulin resistance in young women with polycystic ovary syndrome, a randomized open-label study. Polycystic ovarian syndrome is the most common endocrinological cause of menstrual irregularities and ovarian dysfunction in women of reproductive age, with a global prevalence of 5.5 to 16%. Menstrual complaints such as delayed menarche, oligomenorrhea, and amenorrhea are the most common presenting complaints. Menstrual dysfunction causes stress in the patient and is associated with the risk factor for endometrial carcinoma. Delayed menses in adolescent is associated with subfertility. Polycystic ovarian syndrome, there is a pathophysiology in which there is androgen excess, hyperinsulinemia, and a PCOS morphology. Because of the increased fat accumulation in the body, there is increased insulin resistance also and hyperinsulinemia, which results in decrease of SHBG and resulting in androgen excess, resulting in hirsutism, acne, and other factors, and hyperinsulinemia leading to obesity, metabolic syndromes, insulin resistance, and type 2 diabetes mellitus. In recent evidence suggests that insulin resistance as primary pathogenesis for the development of PCOS, treatment of PCOS in young women is not only essential for regularizing the menstrual cycle, but is also significant to address the long-term consequences. Combined hormonal contraceptives, which are traditionally being considered as the mainstay of the treatment for menstrual complaints, but in a newer concept, the other insulin sensitizing agent like metformin and now ionositols like myo-inositol and D-chiro-inositols are used, which have seen to show insulin sensitizing action. It is now I'll start with my study. It is an open label randomized clinical trial that was conducted from March 2018 to November 2019. The study participants were randomized into two groups based on a computer generated randomization table and the opaque envelopes. For the sample size calculation, considering 100% improvement in menstrual cycle with combined hormonal contraceptives and 65% with inositols were considered, a sample of 30 women in each arm would have achieved the statistical significance of power of 80%. And considering the 10% dropout rates, a sample size of 70 was proposed, and two groups were created with 35 in each group, maintaining a ratio of 1:1. The inclusion criteria were women aged between 15 to 24 years who were diagnosed with PCOS based on the Rotterdam's criteria of 2003. And exclusion were the young women who were pregnant, planning to become pregnant during the study period, and with a body mass index more than 30 kgs per meter square, and with a history of diabetes mellitus or a history of any hormonal treatment and other treatment like glucocorticoids, lipid-lowering agent, and any glucose-lowering drugs in the last 3 months of the study. We started with we took the detailed menstrual history, duration of cycles and bleeding days, with the history of abnormal hair growth and weight gain. Anthropometric measurements was taken. The Ferryman-Galvis scoring and global acne grading scoring was done for all the patients. Ultrasound was performed to evaluate any sorts of pelvic pathologies. Then the two groups were given. One group was given the control drug and the other group was given the study drug, that was myoinositol. In the combined hormonal contraceptive, the composition was 20 microgram of ethinyl estradiol and 3 milligram of drospirenone. And in the study group, we gave the myoinositol and D-chiroinositol combination in the ratio of 3.6:1. That comes out to be myoinositol of 550 milligram and D-chiroinositol of 150 milligram twice daily over a period of 6 months. Our primary outcome was the improvement in the menstrual cycle length and resumption of the spontaneous cycles. Our secondary outcome included BMI, fasting blood sugars, fasting insulin, insulin resistant marker, and hormones were taken in the secondary outcome. We followed our participants over the period of 3 and 6 months of treatment and 3 months after stopping the drug. The compliance of the patient was checked telephonically, and we counted the empty packets during each visit. Progesterone withdrawal was given if the menstrual cycle was not resumed during 3 months period. Statistical analysis was done using SPSS version 12, and all statistical tests for all statistical tests, a two-sided probability of P less than 0.05 was considered significant. This was the consort diagram of our study. We first recruited 140 patients, and then we excluded 70 patients. We randomized it as the 70 patient into myoinositol group and CHC groups, 35 in each of group. There was 2 patients lost to follow up in myoinositol group, and there was 1 patient lost to follow up in CHC groups. And final analysis was done for 33 in myoinositol group and 34 in CHC group. These were the baseline demographic parameters of both the groups, which was similar in all the on the basis of all the history and other parameters that were being considered, all the hormones and baseline investigations. These were the effects. Then we saw the effects. These was the result in myoinositol group and D-chiroinositol group and CHC groups. It was seen that the mean cycle length, that was our primary outcome. In myoinositol group, the baseline mean cycle length was about 3 months, that is 124 days, which over the period of 6 months of treatment was decreased to 57 days. Similarly, in CHC group, it was 3 months, about 3 months, that is 105 days. It was reduced to 30 days in 6 months. By virtue of its action, the cycle got regularized. But it was seen that at 3 months also, the mean cycle length was remained decreased in both the group. Patients regular cycles were attained in 9 patients spontaneously at 6 months interval in myo-inositol group, and oligomenorrhea was seen in 19 patients. Amenorrhea was seen in 5 patients, and these 5 patients were actually the non-responder and belonging to phenotype A. It was seen that the AMH levels, no further change was seen in the other hormonal parameters, significant changes, but in AMH level, it was seen that from the baseline at 6 months in both the group, there was decline in the AMH level. Although in CHC group at 3 months also the level remained the same, level of AMH remained the same, but in cases of myo-inositol group, it was seen that even after stopping the drug for 3 months after that also, the AMH kept on decreasing. That became 6.9. It was also seen that in insulin resistance marker, that is fasting insulin and HOMA-IR value also remains lower in the myo-inositol group as compared to CHC group. Thus, the study showed that spontaneous menses resume in 28% in myo-inositol, 28 women in myo-inositol group after 6 months. In the study, the mean cycle length decreased in both the group, which were more seen in the CHC group. The reduction in the mean cycle length was 54% in myo-inositol group and 70% in CHC group. 3 months after stopping the treatment, 24 patients in myo-inositol group and 25 in CHC group continued to have spontaneous cycles. Significant reduction in the insulin resistance was seen in myo-inositol group as compared to CHC group. AMS showed a significant reduction in myo-inositol group with a p-value of 0.001, less than 0.001. In this study, we also compare the non-responder and responder among the myo-inositol group. There were 5 patients that were non-responder. Non-responder were those patients who did not had spontaneous menstrual cycle for even after 3 months of these drug, and we have to give progesterone for withdrawal bleeding in these patients. In these patients, we have seen that the mean AMH level in non-responder were higher as compared to the patient to the responder patients. That was 15.4 in non-responder and 9 in the responder patients. And we have also seen that in non-responder, there were 4% of the 4 patients out of 5, that is 80% were belonging to phenotype A compared to that of the responder patients. Now I'll move on to discussion. Inositols belong to a sugar alcohol family, naturally present in all the food items. Inositols are the components of cell membrane, phospholipids, and plasma lipoprotein that are involved in the cellular process in signal transduction. The structural basis for inositol phosphate, they are acting as a secondary messenger in a eukaryotic cell. This is the mechanism of action of inositols. In the cases of hyperinsulinemia, this inositol phosphoglycans is produced less in the body. That this will result into the glucose metabolism will not be occurring properly. But when we are giving myo-inositol and D-chiroinositol, that is already being present in the body in different cells, in different composition and different ratios. The myo-inositol is converted into inositol phosphoglycans that increase cellular glucose uptake, and the D-chiroinositol increases glycogen synthesis, thus improving insulin resistance. There was a similar study which compared a comparative study from China. It is a meta-analysis that was done in the year 2021, which was a comparative efficacy of oral insulin sensitizer metformin, thiazolidinediones, and inositols in improving the endocrines and metabolic profile in women with PCOS. It was a randomized trial of 22 trials done from 2005 to 2020, and it was seen that when metformin was used alone for insulin as an insulin sensitizer versus when myo-inositol and D-chiroinositol was used together, it was seen that the myo-inositol and D-chiroinositol was associated with a greater improvement in the menstrual frequency. And it was also seen that when myo-inositols were used, they have a superior to respective monotherapy when metformin is used or thiazolidinedions were used in improving the total testosterone level and lowering the insulin resistance index. Similar as I have told before also, myo-inositol combination and D-chiro-inositol is efficacious in menstrual recovery. This was a study from Iran. It was also a meta-analysis, the effects of myo-inositol versus metformin on the ovarian function in polycystic ovarian syndrome, a systemic review and meta-analysis, which was conducted which included the study from 2009 to 2019. Total of 9 studies were included, and it has also shown that there was significant improvement in between the metformin and myo-inositol. Although the hormonal profile was not improved, there was no change in the hormonal profile, but it was seen that their outcome for modulating the hyperandrogenism and thus improving the ovarian hyperinsulinemia. Strength of our study was it was a randomized control trial, and young women with higher BMI and insulin resistance were included, and limitation was it has a smaller sample size with lack of blinding. Thus, I conclude that in this study that when myo-inositol and D-chiro-inositol was used in combination, there was resumption of menses, reducing insulin resistance and decreasing in serum AMH level, which has a promising result which will be helpful in the future. Thank you.
Thank you so much, Aishi. Can you stop sharing, please? Madhuri, madam, your inputs on this.
Yeah, so first I'd like to begin saying that use of myo-inositol in PCOS is still experimental, and that is the guidelines which is given by the international guidelines which were published in 2018, and now the international guidelines, the updated version is going to be come in May, and we have got it for review, and that still says that there is not enough evidence for using myo-inositol in women with PCOS. The main reason is basically because all the studies, even the meta-analysis which have been conducted, all the studies which are included in this, they have a very small sample size. And basically, some of them are double-blinded, but many of them are not double-blinded. And therefore, there's a lot of bias which can be there. And also, it was seen that there's a high degree of heterogeneity in all the studies which have been published till date. And many a times the inclusion criteria basically were not uniform. So in the study, there were some studies which have definitely shown that there is improvement in the menstrual dysfunction, but it has not shown that there's any improvement in the pregnancy rates, and it has not affected the outcome of pregnancy when myo-inositol was basically being used. When we look at the function of the myo-inositol and dichloroinositol, we know that basically myo-inositol has its effect on gynecological dysfunction, whereas the D-chiro-inositol basically has its effect on the metabolic function, which is there. But this study also, what I feel is it has shown that there is improvement in the menstrual dysfunction. But again, we can see that the sample size is too small, and it was not a double-blinded study. And therefore, we cannot really come at a conclusion that it is really been useful. There was also one study which was published in 2019, which compared myo-inositol and D-chiro-inositol versus metformin. And what they found that its effect on the androstenedione levels, the testosterone levels, and the menstrual function, they didn't basically what they said is metformin is better in improving the general clinical features, but they found that both of them had similar effects. But if you look at the effect on the SHBG as well as on the BMI, it was only metformin that basically increased the SHBG and decreased the BMI, whereas myo-inositol did not do so. So before we really add it to the armamentarium where we are of our clinical practice, we need to really have good evidence for using it. And we know that it is a very expensive drug. but it can be used in those patients who have side effects with metformin. That is my point of view of looking at myoinositol. And probably it could be used in adolescent girls where we don't want to give metformin for a longer time or it is not tolerant. And basically, we do not want to give more of hormonal contraceptive pills or any hormonal treatment.
Thank you, ma'am. I forgot to mention, Aishi, that was a wonderful presentation. You did it so well. Thank you so much. Garima, would you like to say something?
Yes, ma'am. I totally agree with Dr. Patil that myoinositol's use in PCOS, though it has been there since 2 decades, but still mostly used in IVF setting or ART settings, wherein they are usually going for ovulation and pregnancies. It is not generalized, but PCO, we know that they have a heterogeneous population. And one drug cannot be used in different types of PCOS. And also the age group is different. So this study was basically for young patients, adolescent girls, wherein metformin use is usually not used. And sometimes it causes a lot of nausea, vomiting, and the young girls cannot take them while going to their schools and all. Secondly, CHC is a drug which usually there is a parental anxiety, wherein the patients, the parents sometimes they come and they don't want their young girls to take OCPs. So to address that adolescent menstrual dysfunction, by taking experience from our ART evidence that myoinositol improves ovulation rates and pregnancy rates. So indirectly, if ovulation is happening, then there will be spontaneous resumption of menses. So for such adolescent, a group of PCO patients where we cannot use oral contraceptives or don't want to use oral contraceptives, we have an alternative in terms of myoinositol, where we can use them. They have very little side effects. The compliance is good because the gastrointestinal side effects are also not there, and they causes resumption of menses to the tune of 80%, which is fairly good. And secondly, it improves the internal physiology. It is not a withdrawal bleeding. It is a normal spontaneous menses where it occurs after ovulation. And also this study has shown that once CHC is stopped and the myoinositol is stopped, the function or the improvement in the physiology, it is carried on till 3 to 6 months. So there is continuous decrease in insulin resistance, and also spontaneous menstrual cycles are maintained at least every 60 days.
Priya?
Yeah, but one more thing is the mechanism of action of inositols is still not been really known. There's no proven mechanism which has come out still. So basically, we are using it empirically because probably it has a property wherein it helps in improving the insulin resistance. But all the studies which have been published, we in India also have published quite a bit of studies, but most of the studies which are internationally published are basically coming from Italy. And it is at Italy where it has basically been manufactured. And if you look at the number of subjects in each study is nothing more than 20 to 30 or 35. And this is a very, very small sample size. And therefore, drawing conclusion with a small sample size is very, very difficult. As you said, in adolescent where we don't want to use hormones, as I also said that probably it is one of the options.
Yes.
But in other patients, we need to look at the price because it's a very, very expensive drug. And it is not proven to have a positive effect on, especially when you take into consideration the reproductive age group and during pregnancy, where we want to increase the pregnancy rates, or we want pregnancies, or we want to decrease the complications in a woman who is pregnant, wherein we want to decrease the incidence of gestational diabetes.
Charmila, I wanted to ask one question. Can I
Priya, after Priya, madam? Priya.
Okay. Yeah. Yes, Priya.
Yeah. Ma'am, I would like to just make 3 comments from this study. One is that this was conducted in a non-infertile population. So we are not going to apply these conclusions to those seeking conception, because that was the exclusion criteria, number 1. Number 2 is that we have to remember that it's probably because of ethical considerations that you did not compare it with placebo, isn't it, Dr. Garima?
Yes, ma'am.
And so obviously, you are comparing a supplement with a hormone. So the hormone is likely to do better in menstrual cyclicity. But I think the results are very significant because this study had a priori sample size calculation, and that makes all the difference.
Yes, ma'am.
So when you have a sample size calculation, this argument that it's a small study does not stand because you've done it a priori with using the proper power.
Priya, if you read the paper, the sample size calculation was done based on a paper which again had a small sample size. So that
ma'am, pilot studies will only be the basis for sample size calculation. So eventually these will add up. So I think somewhere we have to start. We can't just dismiss it. The third thing is that you've mentioned that there was no blinding. I think the outcome was objective, that is menstrual cyclicity. So, blinding should not affect the outcomes in this. Just one query, how was the allocation concealment ensured in this? I don't know. I think I missed that if she put it in the slides.
Actually, it was done by a nurse in our department, and we had envelopes there. And whenever we would like a patient to have a drug, we would just send it to the.
Okay. I think it's a well-conducted study, and just simply because we are comparing two very different types of drugs, I think the findings are significant. Obviously, we need more on this, but I would like to see if we could do a study on, just lifestyle intervention versus this.
Yes, ma'am. I agree with you. We could have done it, but since the patients are coming, they would not be satisfied only with lifestyle modification. And secondly, ma'am, Patil, it's not just empirical use of myo-inositols. There is a lot of evidence that it's a scientific basis to use inositols in PCOS. I agree that we may need more structured studies in this direction.
That's what I said. Probably it's helpful in a smaller population where we are unable to give the hormones or where we cannot give metformin because of the side effects. But if you look at a larger, because I have been reviewing the second guidelines which is coming, because I'm heading the SIG of Aspire Reproductive Endocrinology, and it has come to us, and there are several studies now which have been conducted, and the evidence what they have got from that still says that the mechanism of action is not known, and its use is basically still experimental. Because I'm reviewing the entire guidelines for them again, because all the societies, once the guidelines are prepared, review it for them and give our comments. So the international guidelines now also, which would be published again in May, would are saying that basically we are using it, but we can use it in a smaller population, but still the evidence for using it rampantly is still not there.
Shuni ma'am, and then Dr. Neerja.
Yeah, I just wanted to ask Dr. Garima that maybe I have missed that the young women were all married, unmarried, and whether they were interested in conceiving, not conceiving.
In my study, one of the criteria was that they did not want immediate conception, and we had taken all our patients were young unmarried girls.
They were all unmarried, so
yes,
the conception did not play any role.
No, and we did not.
Told when they were given myo-inositol or they were given oral contraceptive pills, what were they told?
Ma'am, actually,
why this drug, why that drug?
Yes, we told them that.
Done?
Because when the patients, they come to our institute, most of them, these young girls, they've already used some form of hormones. So they were well aware of the OCP function and everything. So we just told them very clearly that and yes, there were some parents who didn't want them to use OCP. So they directly come and asked me that is there another alternative for OCP, because she's a young girl and she goes around, so we don't want her to take an OCP. So we told them that OCP is a drug which has traditionally been used in PCOS. It functions with the process of ovarian suppression, and there will be withdrawal bleeding every month. But myo-inositol is a drug which is emerging drug which is known to improve ovulation, and ovulation is the basis of spontaneous menses. So this was the way we counseled them, and they agreed and took the tablet.
Basically,
is there a long-term follow?
It does not improve ovulation. Basically, it improves the insulin resistance. It doesn't improve. There are studies which have conducted which have said that it really does not result in ovulation. And even when you look at the studies which are conducted on a a drug which has been used for several decades, and that is metformin. Again, metformin is not a drug which results in ovulation.
Exactly.
It only results in improvement in the insulin resistance.
It
So you cannot tell patients that it results in ovulation. No, you can tell that it helps in improving the physiology of which is there behind PCOS. I mean, as a result. And today we know that it is hypoandrogenemia which results in insulin resistance, because it has been shown that PCOS has its origin in utero. And basically, it is related to the high androgen levels. And these high androgen levels results in increase in the abdominal or the central adiposity, which results in insulin resistance. So all these drugs basically help in improving the insulin resistance, and not it does not induce ovulation at all. I don't agree.
Ma'am, it reduces insulin resistance, and this improved insulin resistance and improved insulin sensitivity in the ovarian milieu induces ovulation. And thus it helps indirectly in improving ovulation rates. And there is enough evidence in our IVF, ma'am, that they improves ovulation rate, and thus the pregnancy rates is improved by using inositols.
Dr. Neerja?
So I love this excited discussion and all the comments I've heard. So I just wanted to make a couple of comments. One is because I see there are a lot of youngsters in our journal club. So based on sample size calculation, just one comment I wanted to make. And that is that whenever, as Dr. Priya said, that we have a pilot study, and we have some evidence that ye hai, difference itna hai, and we go ahead and we do a sample size calculation. But what we can also then do is to do a back calculation once our own results come. And we can at that time ask our statistician that by our results, if you were to calculate the sample size, how much would that now be? And then that gives a corroboration that what we found, and if the next person who has to plan a study based on this, will it still be the same or will it be more? And sometimes we may find it may be more. There may sometimes be a possibility to do an addendum with your ethics committee and request them that we want to do some more cases. Can we add on some more? And if we think that that will not bias our thinking and our results, in some studies that can still be considered. So just a general comment on sample size I wanted to make. But I think this is just wonderful that we've had this very good discussion about the role of these emerging drugs, and the experience sharing, very invaluable. Thank you.
No, but I think, and the study future, when it is conducted, basically it should compare myoinositols with metformin versus combined oral contraceptive pills versus placebo. So that would really tell us whether the myoinositols are really effective. I have also done a very small pilot study where I looked at, just giving myoinositols with any other drug in the infertile group. I have done a study in about 40 patients. And what I saw that though there was some improvement in the testosterone levels, the other hormonal levels really were not altered. And none of these patients ovulated, wherein we did ultrasound scans for them. And we did not give them withdrawal bleed at all. And they, the periods really did not, there must be a reduction in about 10 days of the total time there's to menstruate in. But that's a very small study, and I don't think I would also like to publish it, because basically it's not telling us much more, because probably we require a larger sample size. So I think we have to have all the arms together. I mean, we cannot just compare myoinositol with combined oral contraceptive pills or just with metformin. We need to compare all. We should have to have 4 arms to really get a good evidence when we have to publish, and especially at an international level.
So I think that's how it just builds upon, the evidence builds, then you get this, and then you do the next one and the next one, and then someone will put a meta-analysis together to see if we can combine some of these to get a bigger sample and a better understanding. So all of these go forward to contribute the thinking as it evolves. I think Dr. Ranjana has a hand.
And we need to start somewhere. We can't keep on.
So therefore we have to have multiple you have to compare it with all drugs, because we must realize that it's a very expensive drug. So just prescribe it to our patients, just like that. The thing, I mean, AIMS, you might just give it just like that. But for us in a private practice to prescribe myoinositols with other drugs, it really pinches the pocket of the patient, because your patients have not to pay. It is fine for y'all. But in clinical practice, if the patient has to pay apart from the other drugs what she's taking, it really pinches the pocket.
Ma'am, myoinositol, most of our patients are using myoinositol. It is not very expensive. I know it is expensive. I'll say it's 15 to 20 rupees per tablet. It is, but it's not that we are advocating myoinositol in all the patients.
No, I'm not telling we are advocating.
Just a study to suggest.
As I said, in your group of patients, it is whatever you have done. I really agree with it, because it is the adolescent group where probably we don't want to give hormones. But what I'm trying to tell, if we have to establish an evidence in India, from India, if we have to do a multi-centric study where we have 4 arms and we compare all the 4 drugs, then only we would be able to produce evidence in the Indian population. That's what I'm trying to tell.
Yes, ma'am. I just want to add one thing, that PCOS, I don't think we can have a one wonder drug for all age groups of PCOS and all problems of PCOS. PCOS is a heterogeneous spectrum of, symptoms, a disease. So we need to have a individualistic approach in all patients with PCOS. Some may be more worried about the menstrual dysfunction. Some may be more worried about, they're not worried about whether they're getting menses regularly or not. They're more worried about their hirsutism. Some are only keen on becoming pregnant. So whatever hormones we have, we cannot co-prescribe any drug to a patient. That menstrual regulation will also be there and you can conceive. So it was just an attempt to use a non-hormonal drug to see whether it can achieve or decrease the menstrual cycle, because we know that delayed menses in adolescent girls predisposes them to ovarian dysfunction as well as endometrial hyperplasia. So if we can use this, even if it is a supplement, if we can use it in young adolescent girls and decrease the menstrual cycle length from 3-4 months to 2 months.
I'm not going against your study. I said in an adolescent group.
No, I am also not talking only about my study. What I am talking about is in general management.
For us to come at any conclusion or evidence, we have to have a multicentric study.
Yes, ma'am. Yes, ma'am. Totally agree.
All the drugs have to be compared. That's what I'm saying.
Yes, ma'am. Definitely, ma'am.
Why do you think Indian papers are not accepted in so many international journals? Now I'm an associate editor of fertility and sterility at ASR.
It was published in an international journal.
If you look at it, if a paper comes from India, they say no. I mean, there are many people who really don't even look at it and they reject it right ahead. Why? They feel that we are cooking up our data. And that's been...
No, ma'am, that is not...
I'm just telling you, that's how ASR, the other countries, especially the European countries and the American countries, look at Indian data. I'm there on those journals, and that is why I'm trying to tell you.
Can I have Dr. Yes, ma'am. Can I have Dr. Ranjana Khanna madam's comments before we go on to the conclusion of the program today? Ma'am, you have to unmute yourself, please. Please unmute.
Dr. Ranjana, you have to unmute yourself.
Unmute.
Ma'am, unmute, madam.
Dr. Ranjana, you are muted. You please unmute yourself.
She was so passionate.
Whoever is the host, Komal, you can please unmute her.
I have made her co-host and asked her to
yeah, but she cannot do it, so you can do it for her. Because you're a host, you can do it.
Yeah, now I'm able to do it. I was able to do it now. Actually, my only comment is that I have seen in my years of practice that especially if the girl is a bit overweight, it's very, very essential. First, weight reduction, lifestyle modification is very, very essential. And it is only then that we see a response with the drugs. If she only keeps on taking, metformin does help in weight reduction, but myoinositols don't. But myoinositol in itself, it is not going to work unless if she is even slightly overweight, just tell her to reduce by say 5 kg. So that really brings about remarkable results. So my thought was that while you were doing this study, Garima, if you could have taken those two groups, in one in which the patients got the lifestyle modification done and the others without. So then you could have compared the results. So probably the results with the myoinositols could have been even better. So I'm basically a fan. I'm using that. But in the obese, I like to give, if they're not able to fend for themselves, then it's better to add on metformin because that helps in weight reduction.
Ma'am, there is no confusion. Lifestyle management basically is the first treatment, management for all patients with PCOS.
Yes.
Whatever we are giving, any medication, it is beyond lifestyle modification.
Yes.
So even if we are giving OCP or giving myoinositols, lifestyle modification, physical activity, diet, everything comes before that in my prescription.
Yeah. That is just what I wanted to stress.
Yes, I was wondering, you excluded BMI above 30. Why was that?
Yes, ma'am, because actually we were wanting to, as ma'am said, that they are insulin sensitizers, but they are not as weight reducing drugs, and we thought that it will not be that effective in the very obese patients. So therein metformin could have been a better, or for a research study we did not want to use it, but we are giving it in some of our patients.
And you said there are not much of
homogeneous ones.
Yes,
so
yes. Okay, you wanted to. Actually, I was wondering because myoinositol we are using in a big group of people, even though there is no evidence per se. But there's group, that adolescent group, they do not want to take a hormone. Instead of not giving anything, when you give this, and I'm seeing that it's not complication free. It also causes gastrointestinal complications like metformin. That's what we are seeing with myoinositols also. But when you counsel them properly and tell them correctly, and when they use it, there is a change in the menstrual cycle pattern that we see in the adolescent age group. And we have to start somewhere, Madhuri Madam. It's not like our data or.
No, I never said, but I said we have to have evidence. And we have to develop evidence, and this can be achieved only by doing a multi-centric study. And a multi-centric study will give us we'll have a larger sample size, and therefore arriving at a conclusion will be much easier, and getting an evidence will be much easier.
So let this journal club, let this journal club be the start for that.
Yes, so that is why I said, I mean, if they have already, the AIMS has already done the study, they can prepare a protocol, and probably through ICOG, we can do a multi-centric study. So we will have our own data, and this multi-centric study will be some evidence for the world, because we don't have, we have dearth of patients. We have so many patients, but then we have to do the study properly, analyze it properly, and present it to the world. And that will give us, credibility, and it will also give us evidence.
So Garima, you should help us there. So if you can form a research protocol for us, I think many of us will join, because there needs to be an alternative, because we know that my metformin is not working as they say. It's not a miracle drug for PCOS insulin resistance. And myoinositols, we know that beyond a point that also is not going to help. So somewhere we need to have an evidence to say that this drug for this population. And when you plan out the phenotypes of PCOS, there's one question in the chat box.
And then basically what we have to do is we have to look at the effects of the drugs in different phenotypes. So to look at phenotype A, B, C, and D, because we know that A and B are the most severest type, and they basically have more of insulin resistance because they are hypoandrogenic. And being hypoandrogenic, basically they have more of insulin resistance and hyperinsulinemia. So basically we need to divide the findings again according to the phenotype.
And, and it has an indirect action on the ovaries, ma'am, that we cannot dispute at all. And Garima also brought out in her papers how it changes the hormone profile also. So we can't say that it does not work on the ovary. There is an indirect action on the ovary, and there's enough evidence also that it has got an effect on the ovaries through its action on insulin resistance. Any more comments from anybody before we wrap up the program? Lakshmi Madam, would you like to say something? Dr. Lakshmi Shrikandi.
It was a lovely paper, but Garima.
Yes, ma'am. Thank you,
So
ma'am.
much of, you have given us so much of
Food for thought.
Food for thought. That's great. Because I knew that myoinositol will cause this discussion, because there's no evidence to say that it's useful, but many of us are using in our clinical practice, and we know
and we are getting good results. But as I said, I always combine it with weight reduction in the overweight.
And if you can help us in telling like which patient we should give.
No, but you don't know whether it's because of myoinositol or any other drug, because you're like giving drugs in combination. There were also questions over here which said that whether people are giving combination of metformin and myoinositol together.
Yeah.
So how do you know whether the metformin is working or the myoinositol is working?
Ma'am, we did not.
But not always.
Where you can give a combination also.
No, it has to be a single drug. So what study they have done is pakka, because they have not added any other drug.
Yeah.
But when others are using in clinical practice, I know that they are not using just myoinositol. They are using one combination, but they're using a cocktail of drugs. So how can you say that your effect is because of myoinositol? You cannot say that.
Thank you so much, ma'am. Garima, would you like to say something? Yeah, thank you so much. It is an extreme honor to have such great stalwarts in this program, and it was listening to every thought on cancer prevention as well as on PCOS, two diverse topics, but it gave us so much of information, clinical and academic. Thank you so much. And Garima, you have started a revolution. I think there will be a spurt of papers on PCOS and myoinositols now. Thank you so much. I would like to thank Dr. Lakshmi Shrikande, the chair of ICOG, the vice chair, Dr. Parag Beniwale, all the experts. A special thanks to Dr. Neerja Batla for her for all the help which she gave us for arranging this program. Thank you so much, Dr. Neerja. I'd like to thank the international expert, Dr. Partha Basu, all the national experts, Dr. Bhagi Lakshmi Nayak, Dr. Sarita Shamsundar, Dr. Madhuri Patil, and Dr. Priya Bhave. Thank you, Garima, for your great and excellent paper on myoinositols. It gave us.
Thank you, Charmila. Thank you so much. Thank you for giving us this opportunity to present our research with discuss it with all of you. Thank you, Patil Madam, for giving us so much of insights.
Thank you so much. I'd like to thank Dr. Seema Singhal for the coordination. Thank you, Seema, for all the help you have given us, and excellent presentations from all the three presenters, Dr. Divya, Dr. Himakshi, and Dr. Aishu. Thank you so much for taking your precious time and giving your the discussion and all the points in your papers. It was so well done. Thank you so much. I'd like to thank all the delegates who have joined this program and made it a great success. Thank you so much. Please join for the next Journal Club meeting. It will be in March. Thank you.
Thank you, ma'am. Ma'am, should I stop the meeting?
Yeah, you can stop, Komal. Thank you, Komal. Thank you, Komal and Nilima from ICOG. Thank you so much.
Thank you. Thank you very much.